Ladies, my fellow mommies, we are always so busy, on the go, kids screaming in the back seat, sleeping babies. I have the ultimate hack for you.
Welcome to the Stay Fit Mom Podcast with Krista and Tracy, your go-to girls for health, fitness, and keeping it real in mom life.
If you can't seem to get in a good groove with your nutrition and exercise program, this is for you.
We've coached thousands of women using macros for over 8 years, and I'm well known around here for my 5-day meal prep videos.
What does a macro balanced meal look like?
Hit subscribe to the Stay Fit Mom Podcast and join us for a fun, meaningful journey toward a healthier, happier you.
You got this, Mom.
Hey, everybody. Welcome to another episode of the Stay Fit Mom Podcast. And this is one that I've been most excited about all season. I am joined with Dr. Jake's wife, Katie Kelly, who is here to talk all things perimenopause. Welcome to the show, Katie.
Thank you for having me.
So Katie is a friend. I mentioned this when we were introducing Dr. Jake, a very close family friends of ours that live here in Niceville, Florida, happened to connect us because they know what we do in terms of preventative health care and just working with nutrition, working with women. And so they connected us. And I've been so grateful just because we have wanted medical experts on the show to speak into more than just what we have, which is experience. And we have data on nutrition and things like that. But we know that there's so much more at play. So Katie, why don't you start by just telling me a little bit about your background? We know that you're a nurse practitioner, but tell me about who you are, your family, all of that.
Sure, yeah. Hi, everybody. I'm Katie. I am married to Dr. Jake, and we have been married for 15 years this October. And we have 3 beautiful children. They are 9, 7, and 4. We moved to Alaska 8 years ago now, which was a surprise to everyone in our family to move out this way. But we knew at that time, if we didn't do it, we would never try to move to Alaska, probably in another situation. And we have really fallen in love with being close to the outdoors, and our kids are enjoying snow and skiing and all the opportunities that provides. My career wise, an ICU nurse initially. So I was in critical care for about 5 years. And then I got my nurse practitioner license and started in diabetes, and then transitioned over to cardiology, where I've been for the predominant part of my nurse practitioner career. I am currently running the research department at Alaska Heart and Vascular, and then really just became interested in the hormone therapy space within the last 6 months. A couple of podcasts, and then an education course, and some friends and family that were going through perimenopause. And I knew that this was a topic and an area where we needed more providers with knowledge on the area and more providers treating women.
Awesome. And Stay Fit Mom services a wide range of clients in terms of their age. When we first started about 10 years ago now, we were speaking to new moms, nursing moms, because 10 years ago, we were in that phase. We were those nursing moms. And Krista likes to say that our audience has grown up with us. And so now we're personally past the nursing, we're past the baby phase. And Krista and I are about to be 40 next year. And I have felt all of a sudden, in addition to scrolling and seeing all these perimenopause things on my feed, but I have felt the effects of what people are talking about in terms of just different symptoms of perimenopause. Why do you think that this is so important to women in their late 30s to 50s?
The reason it's very important is, one, because we all go through it. We can't avoid it. So all women are going to go through menopause. The symptoms of perimenopause can affect our sleep, our mood, energy, metabolism, and quality of life for over a decade. And that's critical age of life where your kids are getting older and they are having, as we say, little kids have little problems. And as kids get older, they're dealing with larger problems that you're helping them navigate. And life is busy. And when your mood is affected and your sleep is affected, it can really affect your quality of life. So treating perimenopause will not only help women feel more like themselves, but it will also set them up for long-term health into their 60s and 70s and older decades.
Yeah, I can speak to all of that. It is so true. I feel like my kids are coming to me just with unique needs that are so different from when they were young. And yeah, sometimes I feel like I'm struggling. I don't know if you've seen this video, Katie. I think Beth, your sister, sent it to me. It was cougar puberty. And it's this kid who's like, my mom going through perimenopause, but we're going to bear with her. And she's eating ice cream out of the freezer. I'll have to link it.
I love the term cougar puberty. I saw that oh my gosh, that just makes me laugh.
So let's just clear up. What is perimenopause? I feel like we need to define it. And when does it typically begin?
Perimenopause is the transition period leading up to menopause. Menopause is the point where you've gone 12 months without a period, and that average age is 52. So perimenopause usually begins in the late 30s to early 40s, but it's different for everyone. Hormones like estrogen and progesterone start to fluctuate, sometimes wildly. So we can think of it as a hormone roller coaster. And that's why it's so difficult, because some days we're low and then some days we're extremely high. And so the change in hormones can have symptoms. Having too little of hormones can cause different symptoms, and having too much. So all of these are all of the symptoms from the change in hormones is really this perimenopause time.
For women that are in their late 30s and early 40s, what signs of perimenopause should we be looking out for?
The interesting thing is most signs of menopause that are well known, such as hot flashes, night sweats, changes in your cycle where you're getting heavier periods or they're getting shorter intervals or longer intervals, don't always seem to be the earlier symptoms that we see. The less obvious symptoms are sometimes the ones that are in perimenopause, because this is the hormone fluctuations. 60% of women have a not feeling like myself half of the time. So half of the days, not feeling like myself is a very common symptom in perimenopause. Also, mood changes, anxiety, feeling overwhelmed, irritable, forgetful, you start worrying more. Women can get palpitations, and this is usually triggered by the drop in hormones. So just that change in hormone levels can cause you to get palpitations. We see weight gain, especially the visceral fat, which is the fat around your organs. Skin and hair changes. So think postpartum. When we're in pregnancy, our estrogen levels are like 3,000. And then we have a significant drop postpartum. And as your hair falls out, your skin doesn't look as fresh as it did, at least mine didn't, during pregnancy. Those kind of changes, as well as brain fog. There's joint pain. Women get frozen shoulder more. And then genitourinary symptoms. We're at increased risk of UTIs, incontinence, urgency, frequency. So a lot of women may think that they're just stressed or they're aging, but hormones are playing a huge role.
So interesting. And I know I feel this way when you list off that long list of symptoms. I'm like, check, check, but everybody's different. So how do you know? I was actually talking to another nurse practitioner last night, and she said, women are just like this puzzle because there's so many different factors that it could be. And perimenopause hormone changes are just one of the many markers that could need fixing or need changing amongst other things. So how can women tell if they're experiencing hormone related issues or if this is due to something else like stress, poor sleep, nutrition gaps, things like that?
I think the key is really patterns. If you're seeing multiple changes like sleep disruption or your cycle changes and mood shifts, that's a red flag. Stress and nutrition matter, but if those are essentially stable, unless you're making major nutrition changes or you have a stressful event that is acute in that moment, I think it's at least worth getting evaluated and seen by a provider. But yes, it's difficult sometimes to parcel out all of the symptoms.
That's great advice, especially for the women that are listening to this. We specialize in dialing in that nutrition piece. And so we have had women that they dial in that nutrition piece, and we're tracking all of these other healthy lifestyle choices that they're making. And if they're still really struggling, just to seek out a medical professional that can run these labs and tests. And then, Katie, when you were saying if you see patterns in terms of your mood fluctuation and all of that, Are you talking about patterns in terms of your 28-day cycle? So like day 1 through 5, you might feel some way. And then is that what you're talking about?
Yeah, patterns are just multiple symptoms as well. But yes, if every so often you notice these 2 or 3 days, I feel less tolerant of my children, or I am angrier, or I'm more worried. It really is about documenting your symptoms and keeping track. And then you can look back and see that, hey, this is happening every so often. The hard part about perimenopause is that our cycles are not as consistent. Whereas PMS, your symptoms usually come, for every woman it's different, but it comes at some point 2 or 3 days and you get X, Y, and Z and you go, oh, my period's coming. Whereas with hormones, since we're fluctuating and it's unknown, it may not be consistently the same, but you can start to recognize when you're getting symptoms.
And that's such a good practical takeaway tip for any woman that's listening. I'm the worst at tracking my cycle, Katie. I'm just like, oh, my period started. But as a woman that's 39, that's starting to experience a lot of these patterns, it would only be to my benefit, your benefit, if you're listening, to just get the calendar out and start journaling. Has my margin for stress decreased? Is it cyclical based on my cycle? So I love that meat and potatoes practical takeaway that we all can be doing that amongst all the other things that
All
we're.
the other things, exactly. I'm not good at it either. And I have an IUD, so I don't have a cycle anymore. And so sometimes I assume it's different things, but I should practice what I preach.
It's a good tip. It's a good tip for sure. So why does perimenopause affect things like your mood, your motivation, and cravings? Can you explain a little bit about, you have touched on just how those fluctuations happen, anything specific in terms of, you've used the word estrogen and progesterone and all of those things. How are those affecting moods and motivation and cravings?
So when those levels swing from high to low, rather than settling at a consistent low, which they do in postmenopause times, they can affect our brain, the brain circuits involved in mood regulation, particularly the serotonin, the dopamine, and the GABA symptoms. So we have estrogen receptors in our brain. This is emerging research area. And so estrogen plays a lot larger role than really we even can fully comprehend. So really those fluctuations are affecting our brain and then affect the serotonin and dopamine, which can control our mood. And then as well, some women are just more biologically sensitive to hormonal changes. As you probably know, some women during their menstrual cycles or even during postpartum have a wild range of symptoms versus having no symptoms at all. So some women during perimenopause are just much more sensitive to any sort of fluctuation in hormones. And then in terms of cravings, there's an increase during perimenopause of a hormone ghrelin. It can cause hunger even if someone isn't actually hungry. And then there's some historical research that showed an increase in cortisol, which can lead to cravings during perimenopause. But again, the research isn't very strong right now, and there's still a lot of work to do in that area.
Okay. And what about sleep? That's another big thing. Insomnia. How does perimenopause affect that?
Our estrogen helps regulate temperature and support sleep. So when it dips, women can get night sweats. They get restless or they get that 3 a.m. wake up. Progesterone is also calming, which we'll talk about later. So when it drops, sleep can suffer.
Okay. We talked about lifestyle factors a little bit, but what do you think is going to make the biggest difference if you're working with a patient who wants to explore HRT, which we're going to talk about later? Nutrition, exercise, stress management, what makes the biggest difference during this transition for women?
This question was hard for me because I kept picturing that Instagram reel where a woman she has a face mask on, has the weighted vest, she is drinking her protein shake, she's either doing housework or cooking, and she's trying to do 20 things at once. And it's super hard because we're telling women, you have to eat right, you have to cook your food at night for your children, you have to make them lunches in the morning, you need to wear the weighted vest, you need to strength train, you need to exercise, you need to do all of these things. And there's only a finite period of time in the day. And if you're a mom, you're probably driving your children around in the afternoon for hours on end. So you actually can't do half the things, we're being told to do. Yes, stress management is important. Sleep and sleep hygiene is very important. I think this is usually overlooked for diet and exercise, but having a really good night of sleep really can help us set us up for the day and is also good for long-term health. So I don't think there's one thing that you can do in terms of your lifestyle that's going to have the biggest impact, but I do recommend make a small change. So this week I'm on day 5, I gave up chocolate. I probably was eating, let's be honest, 500 calories a day of chocolate. Like I would have a couple pieces after lunch, and then after dinner, usually after the kids go to bed, we got chocolate chips with peanut butter or dark chocolate with peanut butter or more dark chocolate, or I needed another piece. And it never was a hunger thing. It became a routine. And I finally was like, you know what? I'm going to take the week off of sugar and see how it goes. It's been great. I still like chocolate. I will still eat chocolate, but I made a small change that was attainable for a week time. And then I can then parcel back and say, okay, is this a lifestyle change? How can I incorporate this? So make one small change. If it's sleep hygiene, turn your screen off an hour before bedtime and just make that one change and see if you can stick with it, see if it has any improvement, and then start to incorporate more changes. So when someone throws all this information out at you and you get overwhelmed, just parcel it back. And what is one small thing that you can do to change your lifestyle, to make it a little healthier? When we tell women to do too much, we don't do anything. So I just highly recommend start with one thing that you think is attainable.
Such good advice. Katie, I recently did the same thing, but with protein bars, because in my mind, I was justifying like, I need protein. And I was to the point where I was eating 2 protein bars a day, which were, the equivalent of candy bars in a lot of ways for me. And they weren't satisfying. It was just eating a lot of empty calories in protein bars. And right away, as soon as I eliminated them, the scale went down. I felt like I was in a little bit more control. And we don't like to preach restriction. We like to say that you can have all the food groups. But if you're noticing, gosh, this is just an unhealthy habit that I have, and it's a quick thing that I can eliminate, that'll be a challenge. But a lot of times those things can snowball into other healthy habits. Okay, I eliminated the protein bars. I'm just going to try to eat a little bit more whole foods and swap those out. And like you were saying, the scrolling the screen time before bed. Oh, that's such a good one.
It's hard to do. It is hard to do because your kids are finally asleep and that's a mental break. But
yeah. But I love the picture that you gave in the beginning of the woman on the walking pad with the weight vest. And I feel that I am that woman a lot of days. I'm just trying so hard to do all the things and then feeling like I have no margin for stress. Yeah,
for sure.
So let's talk about exercise. What do you think are certain types of exercise that are more or less important during perimenopause?
I have 3 different answers.
Okay.
So the first answer is for women that do not consistently exercise or that don't exercise at all. So for those women, I would say, can you start something 5 to 10 minutes, maybe 3 times a week, and choose the type of exercise that has the least barriers? Walking for 10 minutes after a meal, or doing body weight squats and lunges and push-ups. The key is starting somewhere. And if you can stick to something for 5 to 10 minutes, then maybe we can grow from that. So for women that just aren't consistent, start small. We don't want you getting in the gym for hours at a time and burning out in a week. We want you just to start somewhere. And it doesn't matter where you start, just start with something that you know you'll do. For women that are consistently exercising, the most important is strength training. So during menopause and perimenopause, we lose muscle. With the decline of estrogen, we are on this muscle loss along with aging. So strength training strengthens bones, it improves metabolism and cardiovascular health. I would find a program from either your favorite online fitness enthusiast or going to the gym. My biggest recommendation, if you are not doing a strength training routine, is to either video yourself or have a friend or a trainer look at your technique. Now that we're in our 40s or almost 40, late 30s, we're more prone to injury. And so even myself, every once in a while, every few months, I'll get a back twinge, probably from some strength training I did that was either my technique or I wasn't rested enough or I didn't warm up enough. And so I think we're just even more prone to injury. So making sure we're doing the right technique. I think you guys were doing a progressive overload program. That's actually one of the best types of strength training programs because we're really trying to build muscle. Muscle is protective, and strength training definitely is a very important tool that we use that we need during perimenopause. And then lastly, I'm going to talk a little bit about VO2 max. VO2 max is a test, and we put the mask over you. And what we do is we put you on a bike or a treadmill and we exercise you to failure. What the mask is measuring is how much oxygen your body can use at max fitness or at your highest level. And what that tells us, it's actually that number is the number one predictor of mortality. So over having cardiovascular disease, over having diabetes or smoking, your exercise capacity is essentially telling us your lifespan. How do you increase your VO2 would likely be the next question for people that are interested in this space. It is a lot of zone 2 fitness, so low intensity aerobic exercise mixed with some very specific high intensity training and then along with strength training. So a lot of exercise, yes, but if we're looking past our menopause years into our 60s and 70s, your VO2 and your fitness level is very important.
That is so interesting, Katie. I don't think I've ever heard that. That is the number one predictor of your mortality. Where can you even get a VO2 test? Do you know?
Dr. Jake, he bought one. So he has a portable one now that he's used it a couple of times. At a cardiology clinic, they have, it's called like a CPET machine, cardiopulmonary exercise tests, and they can do VO2 testing. We have some fitness places in town that also do VO2 testing as well. Usually in medicine, we use it for patients with heart failure as they get sicker. Your VO2 can help us decide if you're a candidate for heart transplant.
Okay.
And so they have it obviously in medical practices, but they also have it in some fitness places. We'll talk about DEXA scans later, and sometimes they have both a VO2 max test that you can get. So I would just Google VO2 max in my city or something and see if any of the tests come up.
Yeah, it definitely sounds like it would be just interesting data to have. Basically, is it like you're sprinting on a treadmill?
So it starts easy. I've had to do a couple of the research studies we did. We had to have tests that shows our machine was calibrated appropriately. And so I got to do it, and I did the bike on one. It starts pretty easy and then it starts just getting really hard. And the interesting thing is it's usually, at least both times I did it, my legs just got so tired. It was the leg fatigue over necessarily the cardiovascular fatigue. So the treadmill, it goes up higher and goes faster. So you're climbing while running. So they are trying to get you to go as hard as possible so that they can get you to failure.
Okay. And so that makes me think of, you didn't specifically say HIIT training, but when you say cardio and strength, is that something that we should be steering away from? I know that there's mixed research. What's your opinion on that, Katie?
I think
Like
HIIT
CrossFit
training
style workouts.
I don't think HIIT training is bad. I think in small amounts, I wouldn't say if someone was doing HIIT training every day, that's likely too much. I do think for strength training, focusing on progressive overload, we're really concerned about muscle growth. And so we really want stronger muscles. But HIIT training and or high intensity intervals will help your VO2. So it's not something that you don't have to shy away from it.
Awesome. How does recovery change for women in this season, and what should they adjust in their workouts?
I would say recovery takes longer. I wouldn't say you necessarily have to take rest days. I'm a firm believer in active recovery. So again, getting the walking in. If you have done a high intensity training session and you're tired the next day, at least get out and walk or ride your bike or do something that's low intensity to continue your fitness. However, prioritize your sleep, good nutrition, and making sure that you are listening to your body. So if you do a good strength training routine and then you try and lift the same weights 2 days later and realize my form is bad or I can't do as many reps, maybe you need 3 days in between heavy strength training sessions. Again, it's very personalized and very individual on how we respond to different activities. And so just keeping track, again, it's back to writing it all down, which is very hard to do, but it's hard to remember what exactly you've done. I think it's harder to remember than it is if you write it down real quick. So just keeping track of your symptoms and making sure that when your body is tired, just do something very easy and light and give yourself another day.
Well, I love, Katie, how you ran the gamut there on the non-exerciser, maybe the person that needs to switch up their routine a little bit. You're a firm believer in active rest. I love that. Okay, so many women during this stage can say, suddenly nothing's working for me like it used to. Why does perimenopause affect weight loss so much? Or does it?
It does. It does. So, due to hormone changes, our basal metabolic rate, which is how many calories we burn in a day, can decrease up to 250 to 300 calories a day. That's the high end. But if that means if we do nothing, so we keep our routine the same, we keep our diet the same, you could gain up to 5 pounds a year.
Wow.
Changing nothing. In general, or on average, women gain 1 to 2 pounds a year. The reason the decrease in estrogen causes, as I've said, decreased muscle mass and increased fat mass. So estrogen protects muscle and metabolism. So when it declines, women have to be more intentional with these lifestyle changes.
You were talking about basal metabolic rate. So I don't know if you've already answered this, but is it a slower metabolism or is it more about changes in muscle hormones and habits? Do you feel like you answered that in that last question, or do you have anything you want to add?
It's both. It's both. And I will say that hormone therapy isn't necessarily associated with weight loss. It is associated with decreased visceral fat, which is the fat that's around our organs. But it doesn't necessarily, getting on hormone therapy isn't going to help because aging also decreases your basic metabolic rate.
What realistic expectations should we have about our fat loss journey in our 40s and 50s?
I would say working with you guys would be a huge help if you do not know how to track your macros or if you do not understand why your diet isn't working. Someone evaluating everything you're eating and maybe giving you tools to change, not everything, but make some positive changes that could potentially put you into a deficit. I would also say we hear that, is it 500 calories a day is a pound a week? However, sometimes 500 calories a day may feel like too much. So is there a way to cut down less and say, let me be consistent with it? We're not looking for fat loss in a month. What we're looking for is fat loss over even a year or more time, because our goal isn't necessarily a bikini picture. We're trying to think long-term for long-term health. So staying consistent with a small change or a small caloric deficit would be more realistic. Look a lot farther out than 1 month and give yourself more time, because it just takes more time. And don't get frustrated, just stay consistent.
I love that, Katie, because that's what we preach so often. We always say slow to lose, slow to gain, quick to lose, quick to gain. And the longer that it takes you, really, the more that you get to solidify those habits that you're working so hard to create. So now we get to talk about hormone replacement therapy, which is all the rage where I go. I joked the other day. I was like, I made a bingo card and I have all these words on it, girls, and I have a feeling I'm going to get bingo by the time I walk out of here. And on that card is perimenopause, HRT, GLP-1s.
It's a hot topic.
Yeah. So it's such a hot topic. Can you explain what it is, how it works, and just try and simplify it for us?
Yeah. So hormone therapy is where we prescribe bioidentical hormones, which it's the same molecular structure as our body's hormones, estrogen, progesterone, and testosterone to patients. So I'm going to go through all three of those. So we'll start with estrogen. We give it as estradiol. It's the workhorse of the three hormones. It helps with vasomotor symptoms, hot flashes, and night sweats. It's the hormone that protects bone health and potentially, if given at the right time, heart health and brain health.
Okay.
The preferred method usually is to start with transdermal, which is just the estrogen patch. It decreases any risk of clot and is usually that's our first line of treatment. It allows more stable levels in your blood. And usually we can relieve symptoms with lower doses than other forms of estrogen. Other forms that can be prescribed, there's estrogen gel, estrogen cream. There's a ring that you can insert vaginally that stays for 3 months. And then there is estrogen pills and estrogen injections. There's a whole wide range, but in general, for most women, if they can tolerate the patch, we like to start there because it is a safer estrogen. Then we'll move on to progesterone. Progesterone we give because it protects the endometrial lining. So if you have a uterus, you have to have progesterone. This is normally oral micronized progesterone. We can give it nightly, or we can give it 2 weeks on and 2 weeks off. For women, sometimes prefer that if they are still having normal cycles. Progesterone, about a third of the women, it actually is almost like a sleep aid. It helps you sleep better. So some women love it because it just helps them go to sleep and stay asleep. A third of the women probably don't have a lot of symptoms, and so they take it because they need to, but they don't notice major benefits or side effects. And then there's a third of the women that have severe side effects, I would say. I had a patient that she had hormonal side effects where she was very angry and irritable when she started the progesterone. And so some women get severe bloating and they don't tolerate it. If they can't tolerate oral, you can insert the pill vaginally. And that sometimes, because you're decreasing the first pass through the liver, can help with symptoms. Otherwise, an IUD, the Mirena is an IUD. It has progesterone in it. It can sometimes be beneficial in women because during perimenopause, you can still get pregnant. So it acts as both birth control and then protects the endometrial lining. So that's progesterone. Lastly, we'll talk about testosterone, which isn't as well known, I would say. But if we took our testosterone level and estrogen level in our blood and put them in the same unit of measurement, we actually have more testosterone than estrogen.
Okay.
And women who have been on birth control also are at risk of having a lower free testosterone level due to birth control causing an increase in this sex hormone binding globulin, which can bind to free testosterone and cause a lower testosterone level. So the treatment of testosterone is tough, at least in the United States. There is no FDA approved testosterone. Australia does have a testosterone cream approved for women. So it's not that it's nowhere approved. It's just in America, it is not approved. Hopefully yet. Let's hope we make some changes. The dose for women compared to men is about 1/10 of the dose. So what we use in general, we prefer topical testosterone, and then we prescribe what they give to men, testosterone cream or gel, and we just prescribe it at 1/10 of the dose. What can testosterone do? It can improve stress incontinence, muscle tone, libido, and energy. The maximum effect, it may take a couple of months to really see all the benefit. And then lastly, which I probably should have said first, is vaginal estrogen, also vaginal DHEA. I'm mainly talking about vaginal estrogen because vaginal DHEA is harder to get, more expensive. So there's more hoops to jump through to get it. But vaginal estrogen is a very safe way to start, I guess, with hormone therapy. Our microbiome changes during perimenopause and menopause. We lose acidity and can have frequency, urgency, dryness, leakage, increased urinary tract infections, pain with intercourse. So, vaginal estrogen, it's not systemically absorbed, meaning it's not really going to affect your blood levels, but it can help with all of the genitourinary symptoms of menopause. Again, the results for that can also take a couple of months for maximal benefit. This one is important. One of the doctors I follow, Dr. Rubin, who I'll probably talk about a little bit more, she talked about how if we put all women, especially even postmenopausal women, on vaginal estrogen, we could save, I don't know if she said 20 to $60 billion
Oh my goodness.
from healthcare costs of UTIs in women, because when we get older, women get UTIs, and then that can cause sepsis, which is the infection spreads to your bloodstream and can cause you to be very sick. In the hospital, when I was a critical care nurse, we were always trying to prevent women getting urinary tract infections because it could just be detrimental to their hospital stay. So vaginal estrogen, almost everyone should be able to be on it. There's one group of patients that may be on a drug for cancer that can't, and we'll get to that here in a minute, but it's a huge benefit for women, and think of it as like a lifelong thing to be on because of how many symptoms it can prevent. Once you stop taking it, the dryness and the symptoms can come back. With all of these hormones, each person is very individual and are going to tolerate the hormones differently. So I recommend we start with one hormone at a time. You get the dose right. A lot of times we start with estrogen, get the dose, make sure you're tolerating okay, aren't having symptoms, and then move on to make the fit for each individual what hormones they need.
The very first word that you used was bioidentical. I've heard you don't want to get synthetic. Is that?
And we'll get it. So synthetic hormones. So birth control is usually synthetic hormones.
Okay.
And the Women's Health Initiative, which we'll go over here in a minute, they use synthetic hormones. The education course I took, she said, if you want to compare synthetic hormones to bioidentical hormones, compare gummies that look like strawberries to actual strawberries. They are not the same thing. We need to realize how different they are. And so a lot of research was done on synthetic hormones, and we're still trying to get more research on the bioidentical hormones.
Okay. So you said start with estrogen. I'm assuming if you were to go get lab work, do they show you your levels of all of these hormones throughout your cycle? How does the testing work in terms of you go and get your labs done? How does my doctor know, or nurse practitioner, how does she know how much estrogen to give me and when to take it?
The guidelines say that we don't actually have to test the lab levels of hormones before starting hormones in perimenopause. They are a tool for treatment. Normal estrogen levels are 50 to 150. And so if you start estrogen, we can at least know if you're absorbing it, because if we get a level back that's not in that range, we know that maybe you're not absorbing it or you're not getting enough. And then a lot is driven by symptoms. Are your symptoms resolving? If they're not, we can try increasing the dose. If you start having breast tenderness, abnormal bleeding, or some side effects that make us think that you have too much estrogen, we can back off. So labs are a tool, but they're definitely used in conjunction with symptoms.
This kind of makes me think when we're like, the scale isn't everything. We want to go off of how you feel. It's just one data marker. That's really helpful to know.
Yeah.
And then I don't know if this is way off the wall, but I've heard that progesterone is the safest thing to start with. Is that anything about that?
So yes, progesterone can be. I would say the safest thing if you're having genitourinary symptoms is start with vaginal estrogen. That one's super safe because you're not systemically absorbing it. Progesterone, it's great for a third of women. It's fine for a third of women, but then the third of women that have these bad side effects, they don't like it. So I wouldn't say it's necessarily safer. It depends on what a woman comes in with. The hormones are a toolbox, and each woman has different concerns. If you come in and you are overall doing okay and your only issue is low libido, maybe we consider testosterone first. If you come in and you're worried about sleep, sure, let's start progesterone first because that can help you get some better sleep. And then with estrogen, if you have vasomotor symptoms, we're really trying to solve the vasomotor symptoms and hot flashes and night sweats. Let's start the estrogen and see how you do. The estrogen is usually the one, anecdotally, what I've heard and is that estrogen is the one that helps you feel more like yourself. But again, it depends on a woman's symptoms. It depends on her concerns. And so it's really a toolbox where we can start one, see how it goes, try another one. It is challenging because you're just trying to find the best dose of the medicines for each individual. It's not one size fits all.
Then who is and who isn't a good candidate for HRT?
Most healthy women are good candidates, especially if they're under 60 or within 10 years of menopause. If you have a history of cancer, if you have cardiovascular disease, you have a clotting disorder, talk to a provider that has a lot of experience in menopause treatment to help guide your decisions. There's always a concern with taking medications. All medications have potential risks. What we don't always discuss with patients is what is the risk of not taking medication? Long-term bone health for hormones, or is there the potential for an increased risk of dementia or heart disease? We really want to balance the risk and benefit. And I think there are providers that will help women guide their decisions if they have a history of some of these other illnesses.
So interesting. Dr. Jake and I talked about that too in terms of GLP-1s and the peptide movement. Do the risks of being obese outweigh the risks of being on a peptide? So yeah, that's pretty much what you're saying here too. We want to weigh the costs for sure on both sides. And so speaking of risks, there are some older studies that are scary in terms of HRT. So what does the most current research say about its safety?
Let's start with the older study. So before the Women's Health Initiative, women were getting hormones. They used to just give estrogen. They realized that can cause the thickening of the endometrial lining. So they needed to give progesterone as well. And then the Women's Health Initiative came. The average age of women in that study was 63. So not in perimenopause and definitely 10 years past menopause. And then they used one dose. So everybody got the same dose of the medication and it was synthetic. It was not bioidentical. So they were using synthetic hormones. What did it show that was positive? It showed a decreased risk of fractures. It showed decreased diabetes, decreased colon cancer, decrease in overall mortality. From that study, it didn't show any change in your cardiovascular risk. So there were two groups. There was a group with uterus and group without uterus. The women without a uterus, again, only had to get estrogen. So in that group versus the placebo of that arm, women actually had a decreased risk of getting and dying of breast cancer. The women that were getting the combo, so the progesterone and the estrogen, again, there was a placebo group that they don't get the medication and the group that was getting the medication. So the fact that came out that stopped essentially everyone from prescribing hormones was that there was an increased risk of getting breast cancer by 24%, not mortality risk, just getting it. However, if we look at your absolute risk, so our absolute risk is 0.1%. So if that increases 24%, that means about 1 in 1,000 women have an increased risk of they're going to get diagnosed with breast cancer, but they will not die from breast cancer. So that was the fact that essentially shut down hormones worldwide, I would say.
For women, yeah.
For women, yes. So current research, I will preface this that saying there is still a lot of work to be done in the research field. Traditional research did not include women. For a long time, women weren't included in research studies. The main reason is we can get pregnant and the risk to fetus. And so now when I do research studies, if women are of childbearing years, they're signing consents that say they will use 2 forms of contraception while they're in the study because they are worried about medications and effects that it could have to babies.
Yep.
Newer research does show that modern hormone therapy, especially transdermal estrogen and micronized progesterone, is safe and beneficial for most women. Estrogen prevents bone loss, and the transdermal estrogen definitely has a less risky profile. There is a new timing hypothesis theory, which means early initiation of hormones during perimenopause, within 10 years of menopause, or age less than 60, may have better cardiovascular or brain health, cardiovascular prevention, or better for our brain health. It does slow heart disease. So there was an imaging study and it showed decrease in coronary calcifications, which means the arteries around our heart. It would decrease any sort of blockages in your heart. It does improve our lipid profile, so your cholesterol levels. It can possibly decrease all-cause mortality. It improves insulin sensitivity and glucose metabolism, which is important for weight management. There's a potential decrease in cardiac events, even among women on testosterone therapy. Again, low dose vaginal estrogen is the go-to treatment. It's been studied for vaginal dryness, painful sex, many urinary symptoms caused by menopause. It restores the lining and pH. So it definitely lowers recurrent urinary tract infection risk. This one, in a review of the literature, there was no increased risk of breast cancer recurrence within 5 years in women with a personal history of breast cancer who were using vaginal estrogen for genitourinary syndrome of menopause. So there is slowly becoming more and more research in this field. As I said earlier, there's a neuroscientist who is studying estrogen receptors in the brain. And there's more estrogen receptors as we're entering menopause in our brain. Is that because our brain wants the estrogen? There's a lot of different theories out there. We just don't have enough quality data to go off of. So we need more research in this space.
I feel like there's a lot of positive research there as well. So, yeah, I think it goes to what we said with a lot of weighing this out with your provider and just determining the best course of action if your symptoms get life altering, right?
Yeah.
Okay, so I know that a lot of people do not want to take medication or HRT, hormone replacement therapies. So, what non hormonal medication lifestyle shifts can still be effective with perimenopause?
I would say, yes, lifestyle factors are still going to be helpful. So, weight management, regular exercise, limit triggers. So, that would be alcohol, caffeine, spicy foods, potentially SSRIs, and it's an antidepressant medication, can help for, think of Lexapro, Prozac, are two SSRIs that can help for hot flashes. There are some herbal products, but there's really inconsistent results on if those actually help with menopause symptoms. So focusing on, we won't go into supplements, but focusing on a healthy diet with fresh fruits, vegetables, making sure you're eating the perimeter of the grocery store, exercise, sleep management, stress management, focusing on all the lifestyle factors can have a positive impact.
How can nutrition support women through perimenopause and into menopause?
Yeah, I would say the best diet for menopause is probably just overall healthy eating with a variety of nutritious foods. Different for bone health, we can focus on calcium and vitamin D. Heart health, the only diet that has shown improvement in cardiovascular health long term is the Mediterranean diet. Think fish, olive oil, vegetables, nuts, berries, but it's hard to make a whole diet out of those items. Symptom management, again, like I said before, for menopause, you're avoiding triggers, alcohol, caffeine, spicy food. Weight, if you're to keep our weight management, high protein, which we'll focus on here in a minute. And then brain health, omega-3. So focusing on different things that can help different parts of our body. There was a study that showed an increased intake of fresh produce decreases visceral fat, which is, again, the fat that's around our organs is the fat that we're more concerned about. And then other negative things, so processed foods in sugar.
That kind of just brings us to our next question, which is, are there nutritional deficiencies in women that could worsen their symptoms?
Yeah, I don't know how much folks know about. It was a long time ago, and America went with low fat instead of low sugar diets, and everything turned low fat, and we added sugar into everything. And the research behind it seems shady for low fat. And actually, someone was proposing sugar is what's bad. And now I think we've learned that sugar is bad. It can cause more cravings, it can cause fluctuations in how we feel, it can cause crashes. And so, sugar is definitely something we want to be aware of because everybody adds it into everything. And processed foods has been shown to be something that can increase comorbid conditions later in life. And we see a lot of processed foods in our diets. The main common deficiency is fiber. It's probably the most underconsumed nutrient. So much so that Jake went out and bought psyllium husks, or he ordered on Amazon, let's be real. And so I saw him drink it one morning and I go, oh, okay, sure, I'll increase my fiber intake. So you put a tablespoon of psyllium into water and then you just drink it. And it has 5 grams of fiber. I tried it and it was hard to get.
Oh no.
It's weird consistency, but I was doing it in the name of increasing my fiber intake. Women are supposed to get 25 grams. It's hard to get 25 grams of fiber. Yeah. I don't know that I would recommend that to women trying to increase their fiber intake unless you're a glutton for trying interesting things or chugging down interesting textures. But fiber intake with beans, legumes, lentils, raspberries have a lot of fiber, pears have fiber, chia seeds. Just Google high fiber foods and see how you can incorporate those into meals would be helpful.
And that's across the board. Dr. Jake said the same thing for how do you want to naturally increase your GLP-1 hormone? He was like fiber. So that is a commonality. If you're looking for weight loss, if you're looking to balance your hormones, yeah, fiber is just something that we're hearing so much about for sure. 25 grams a day, girls, we got this. The next question is, if a woman could make just one nutrition change during perimenopause, what would have the biggest payoff? Is that fiber? Is that what you're going to say?
No, I wanted to say fiber. Man, I was like, oh, I'm going on. And the only thing I don't want to say is protein because everybody's talking about protein, but I'm going to say protein, sadly. It's true. Protein helps maintain muscle mass and strength. It supports your bone density. It regulates the metabolism for better weight management. It increases feelings of fullness to prevent overeating. There's a lot of research being done on the 88 guidelines for protein versus probably what you guys recommend or what other professionals are recommending, which is much higher intake level. I will say, I used to always be hungry at 10 a.m. Most mornings I was hungry at 10 a.m. We switched our breakfast to where we eat Greek yogurt, either the Faye, Siggy is a good brand, or Kirkland has a great brand, where it's about 100 calories and you're getting 18, 19 grams of protein.
It's huge, yeah.
And then you add a scoop of protein powder, which again, people will either love that or hate it. It takes a while to mix, but once you get your mixing routine in, it is okay. It does mix. We like Equip protein. And then we add the berries and we add the high fiber, high protein, a little bit of cereal to give it a crunch or some peanut butter or chia seeds. You can add whatever you want, but that's giving you 40 plus at least grams of protein to start your day. And that keeps me full to lunch. And there's other high protein breakfasts out there, but sometimes not having a routine and staying the same is just easier for my mental health because I don't have to think of new ways to get the protein in. And once I get sick of it, maybe I'll come up with another
one. Yeah, that's great.
It does help. Protein, yeah. There is something with protein, and we really are trying to prevent muscle loss. And a high protein diet really does help you stay full and then helps your muscles.
Yeah, we always say too, it's so much harder to catch up on your protein as the day goes on. We get busier, we get tired. And so also helps with glucose regulation too, just right off the bat, you're starting your day. I think that is probably one of the biggest secrets, I guess, is get your 50 grams of protein by lunch and it will be a game changer in terms of being able to hit your protein goals the rest of the day. So that's a great recipe. Greek yogurt, protein powder, berries. Did you add anything else in there?
Yeah, I add the kashi cereal that has fiber.
Oh, yes. The fiber kashi cereal.
I like a little peanut butter because it just gives it a little.
Yep.
And then chia seeds. So my husband's calories, he probably has like twice as many calories because he's like 2 tablespoons of chia seeds and like he just adds all of it in, but you can add bits and pieces of all of it. I had a patient, I will say that she wore, and I've worn them too, the continuous glucose monitor. And if she had a high protein breakfast and nothing else changed during her day, it didn't matter what she ate. When she started her day with a high protein breakfast, her blood sugar stayed stable. If she did not start her day with high protein, her blood sugars would fluctuate, even if the rest of the day was the same. So there is something to be said for protein.
All right. So tangible takeaways. Let's make sure that you're marking your cycle, ladies, and that you're getting your fiber, 50 grams of protein before lunch. I love it. And we're almost getting to the end. Katie, thank you so much. So far, this has just been so great. So now we're getting to the part of medical guidance and advocacy. What labs or screenings should women ask their doctors if they suspect they could be going through perimenopause?
So current guidelines say you don't actually have to have blood work before starting hormones. However, if you're in your 40s and like me, I don't have a primary care provider. I did get my labs drawn at work. I got them drawn to evaluate them. But if you're done having children and you haven't seen your OB in a few years, should consider getting a primary care provider. You should get a basic set of labs. So a basic metabolic profile, a hemoglobin A1C, or which is your average blood sugar over time, a vitamin D level, your thyroid panel, iron and ferritin, and look at your lipid profile. So get a basic set of labs, and then you can evaluate just where you stand. If you're getting hormone labs, again, as I said, it's a tool. It's not the only answer, just because during perimenopause, we are fluctuating so frequently that it can be hard to interpret those labs. But the labs can be a sensitive estradiol or estrogen level, progesterone level, testosterone level, the sex hormone binding globulin. Again, this is increased on women who have been on birth control and can affect your free testosterone level. Get the FSH, LH, prolactin, and again, thyroid is with the hormone labs. The other one that I want to recommend is a DEXA scan. So a DEXA scan measures your bone density, your body fat, your muscle mass, and your visceral fat. Guidelines now say women, I think it's over 60 or 65 is when we can start getting it. However, a cash pay amount for places is usually around $150. For perimenopause, menopause, there is an average reduction of bone mineral density loss of 10%. So having a good baseline and knowing what your muscle mass level is, what your bone density is, we need to know ahead of time, because if we start seeing changes, we'll know that we need to, again, adjust and make changes.
About that. So when you say just get a general blood work from your primary care provider, that's going to give you a basic metabolic profile, and the hormone labs are not going to be tested unless you specifically advocate for that, correct?
I would make sure if someone is checking your hormone labs that they are a provider that is comfortable and understands a lot about hormone replacement and also about menopause in general. And this kind of goes into the next question, is advocating for yourself. So one, educate yourselves. I listened to, I think it was Dr. Mary Claire Haver's podcast. I think she was on Armchair Expert, which was an interesting place to find a gynecologist on Armchair Expert. But it was a good listen, and I was enlightened then. And then followed by Dr. Rachel Rubin. She has a website, but she also was on Peter Attia's podcast. And that podcast was when it clicked for me that we need more providers treating women in perimenopause. So listen to those podcasts because they go even deeper into the hormone replacement and more of the symptoms and what to look out for. And then there are books. There's a book I'm reading right now called Estrogen Matters, or you can read The New Menopause, and give yourself time. Again, you're able to read it so you can go slow, you can mark things, you can see if your symptoms align, and then see the treatment. And then there's a list of providers on menopause.org that treat menopause. And so if you are struggling and someone is not listening to your symptoms and you feel like they're not helping in this hormone space, definitely go look on the menopause.org, and see if you can find a provider in your area. There are online providers. I have not done enough research on them, but I believe they use compounding pharmacies. The risk with compounding pharmacies is that the drugs that they use, those pharmacies, they aren't FDA approved. So they're just not the same. They don't necessarily aren't the same as what you would get from a traditional pharmacy. So I'm not saying that they don't work, but just do your research and make sure reputable place to do that.
Beyond symptom relief, what are the long-term benefits of addressing hormone health, bone health, cardiovascular health, mental health?
So hormones do impact long-term health. Now we're treating the symptoms, but long-term, we're trying to protect our bone health. As I said, a 10% loss of bone mineral density is huge. The risk of osteoporosis in women is significant. And if we can prevent fractures later in life that cause debility, hip fractures, I don't know what age it starts, but in your 70s, 80s and beyond, it's like a 50% annual mortality rate. And then of those who do not die, they have debilitating symptoms where they don't get back to normal. So it's hard. Fractures, we really want to protect ourselves later and stay strong and fit later. Cardiovascular health and brain health. Women have an increased risk of Alzheimer's. We don't have enough data, I would say. I'm not an expert in that area at all. However, if there is a link and we're providing estrogen to the estrogen receptors in our brain, potentially we're helping our brain cognitive function later in life, along with our cardiovascular health. If we can prevent heart attacks and we can prevent fractures and we can prevent all these things from happening later, now, I think that's essential for our quality of life.
And that is such a different way of thinking about it. I think a lot of times for me, I get very fearful of putting anything in my body. I think my body's doing what it's supposed to do, but if your body is screaming at you, it's giving you reason for concern to think that taking hormones now would prevent me from breaking a hip later. That's pretty wild to think about, especially when my previous train of thought that I go to often is your body's just doing what it's supposed to do. I don't know if you can speak to that at all, but
I had a patient and she was on estrogen and she had a heart attack and they stopped it. They said, oh no, she was on estrogen since her 20s. She had a hysterectomy young. And so she was on estrogen and had a heart attack at whatever age. And they're like, oh no, you cannot take estrogen anymore. And now she has been on so many different drugs for osteoporosis and has had surgeries and has had all these issues from her osteoporosis. And part of me thought the other day, what if they just let her keep her estrogen? Because after her heart attack, she got on all the right meds for her heart. So she was protected with probably a statin and aspirin and the medications that we use for heart disease. So if they had kept her on the estrogen, what if we could have prevented some of this? Again, I don't know. We'll never know. But you start to think about what we could potentially be saving someone from later.
yeah. Yeah. Okay, what would you say to the woman who just feels like I'm in perimenopause? This is it. This is the beginning of the end for me.
I would say it's just the beginning. I turned 40 this last summer and I feel my kids are getting older and I will say somewhat more self-sufficient. There's more time to think about health and wellness. A little more time. Let's be real. We're all still very busy. I want the narrative to change on hormones and menopause because now that it's having a moment and people are hearing about it, women should feel empowered. We can make a change and we can treat menopause to where we feel like ourselves again. That's what we want. And so I think it's the start of a new season of life. Yes. But I think we should be excited about it and excited about finding our health and wellness in this time.
Love that. All right, leave us with some final words, Katie. I feel so much more well-educated to walk into my own provider and ask for things. So thank you. And I know this is going to be what a lot of women feel as well. So final words of encouragement. What's one piece of advice you'd give every woman in her late 30s through 50s who wants to thrive through this transition?
Don't settle for the symptoms. Don't settle. As I said, write your symptoms down. there is treatment. So don't just accept that we're going through these symptoms and that nothing will make it better. Educate yourselves and go to a provider and advocate for yourself. And then second, I know I was only supposed to say one, is give yourself grace. And I have been getting overwhelmed with children's activities, and this is the first year they're in different places at different times, and it's stressing me out. And I have an aging dog that's pooping in the house now, and I have a puppy that's wild and eating everything he can get his hands on, and it's stressful. Our lives are very stressful. We don't understand what everybody is going through individually. So take a moment and give yourself grace for whatever situation you're in. Try and make small changes that you can just stay consistent with. And if you have a bad day, start the new day refreshed and ready to go again. We're training for life. We're training for being grandparents and chasing kids, and think about the future, and the changes you make today will set you up for success.
Love it, Katie. Thank you again so much. Katie, if our listeners want to find you, where can they find you? With Dr. Jake?
Yeah, find me with Dr. Jake. I'm going to have him post some information on this. There may be more from me later. I started an Instagram handle. It's AK Longevity. However, there's probably 3 or 4 posts because kids and life and time. And so I haven't actually grown it, but maybe this will be the impetus that gets me moving.
I hope it is, because it's so well needed. Thank you again, Katie.
Yeah, you're welcome.
Another great episode of Stay Fit Mom podcast. Thanks for tuning in. We'll catch you next time.
We appreciate you tuning in to the Stay Fit Mom podcast. If you enjoyed today's episode, don't forget to subscribe and leave a review. Connect with us on social media and head to stayfitmom.com for more resources and tips. You've got this. See you next time.